Under a microscope, a single cancer cell divides relentlessly. Scaling out from the individual patient to a national healthcare system transforms this biological crisis into a macroscopic economic calculation. Expanding a screening program theoretically detects more cases, yet pushing for absolute clinical perfection mathematically breaks the system's ability to function. This chart tracks successive colon cancer screening tests against marginal cost per case. The initial test operates efficiently at $1,175. As the program pursues harder-to-detect cases, the curve violently asymptotes, reaching over $47 million to find a single additional case. That $47 million figure represents the specific price of locating just one extra patient. Health economics is the mathematical science of managing this asymptote to avoid systemic collapse. Clinicians often view the implementation of economics in a hospital as a bureaucratic mechanism for budget cutting and denying care. Classical macroeconomic theory targets the maximization of general subjective welfare, a broad metric for individual utility and satisfaction. Health economics utilizes a specific framework called extra welfarism. This model shifts the primary objective to the maximization of objective health outcomes, rather than consumer satisfaction or financial savings. Optimizing these outcomes requires medical professionals to work within the universal resource constraints that bind all healthcare delivery. Treating economic concepts as triage tools provides the only viable path to maximize aggregate population health. Resources are inherently scarce, even as human health needs remain infinite. In any hospital ward, spatial constraints and staffing ratios dictate the limits of care. We can model these limits by examining the trade-off between funding inpatient treatments and outpatient clinics. Dedicating all resources to the outpatient ward allows for 50,000 patients, but leaves the hospital with zero inpatient capacity. Reallocating resources to treat 3,000 inpatients forces a direct reduction in outpatient capacity, dropping it to 20,000. Maximizing the inpatient ward to its 5,000 patient limit eliminates the outpatient ward entirely. This trade-off defines the concept of opportunity cost. Opportunity cost in healthcare consists of the specific health benefits sacrificed by abandoning the next best alternative treatment. The true cost of any new medical intervention is the direct health gain lost by a different patient elsewhere in the system. Medical policy decisions center on the incremental question of how much of an intervention to provide, rather than all or nothing binaries. Returning to the colon cancer data allows us to isolate the yield of each incremental test, specifically the number of additional cases detected. Efficacy drops sharply after the initial tests. By the third screening, the return falls to 0.45 additional cases. The sixth test provides a statistical near-zero return of 0.00028 additional cases. This decay is the result of diminishing marginal utility. As screening coverage expands, locating the few remaining undetected cases within an increasingly healthy population becomes exponentially harder. Any health intervention inevitably faces a mathematical decay in its capacity to generate new health benefits as it scales. Health systems manage this decay through three distinct tiers of efficiency. Technical efficiency is the operational goal of producing a service with zero wasted physical inputs, like equipment or labor. Economic efficiency seeks to produce that same service at the absolute lowest financial cost. Allocative efficiency is the ultimate objective, ensuring that the pattern of medical output exactly matches the actual demands and needs of the population. Overlaying marginal benefit against marginal cost reveals the exact boundary of allocative efficiency. The mathematical imperative is to continue funding a program only as long as marginal benefit remains higher than marginal cost. This imperative ends exactly where the two curves intersect. Pushing the screening program past the second or third test violates this boundary, as the skyrocketing costs begin to actively destroy health gains that could be achieved elsewhere. Pursuing a clinical program to its absolute maximum limit represents a failure of allocative efficiency. On a macro level, the $47 million required for that sixth colon screening test is stolen directly from other sectors. Reallocating that same $47 million to infectious disease prevention generates massive, quantifiable blocks of health gain that the screening program simply cannot produce. For example, those resources could fund the large-scale labor and materials required for malaria prevention. The same capital could instead secure critical priorities in pediatric care, maternal health, or HIV treatments. Ignoring marginal analysis leads to implicit rationing, the process where budgets run dry organically, denying care to patients without a data-driven strategy. Inefficient spending in one department directly harms unseen patients across the rest of the health system. Medical professionals face a heavy moral burden when forced to cap treatments or ration care. Extra welfarism addresses this burden by demanding explicit, data-driven rationing over emotional guesswork. The unbreakable rule of health economics states that medical intervention is only authorized when the health gain it achieves outweighs the health gain it abandons. Calculating the margin serves as the ultimate clinical triage tool, engineering every finite resource to buy the maximum possible human life. This line graph tracks U.S. healthcare spending as a percentage of GDP from 1960 to 2021. Today, it consumes nearly 1/5 of the nation's economic output. Despite spending $4.2 trillion, U.S. health outcomes like life expectancy remain strictly average compared to peer nations. Many medical professionals and citizens view healthcare exclusively as a clinical issue, a biological problem solved by medical science, isolated from market forces. But every clinical intervention, from a routine checkup to open-heart surgery, requires the allocation of scarce resources. It is an economic transaction. If economic principles govern the allocation of these resources, we have to ask why this specific market operates with such intense dysfunction and high costs relative to other sectors. The system isn't operating randomly. Healthcare costs are driven by rational actors, optimizing their economic positions. The problem is that the standard free market model they operate within is structurally distorted. 3 specific variables warp the traditional market: uncertainty, asymmetric information, and the reliance on third-party insurance. To understand how $4.2 trillion moves at the macro level, we have to map how these 3 variables alter human behavior at the micro level. Treating healthcare purely as a clinical requirement ignores the powerful economic incentives that dictate life and death decisions. Without mapping these incentives, systemic reform is impossible. In a standard market, rational decision-makers optimize consumption by plotting the marginal benefit, the value of one more unit, against the marginal cost. Consumers buy up to the point where additional benefit matches cost, labeled E0. Consuming past this point represents pure economic waste. In 1963, Kenneth Arrow published a work that challenged the standard way economists viewed healthcare. Arrow identified the first major distortion: uncertainty. Unlike buying groceries or a car, human illness is unpredictable in both its timing and its severity. The second distortion is asymmetric information. There is a massive knowledge gap between a highly trained medical provider and a vulnerable patient. The patient rarely knows exactly what they need or how to evaluate the quality of the treatment they receive. This strips them of standard purchasing power, forcing them to rely entirely on the physician as a trusted agent. Because severe, unpredictable illness carries catastrophic financial risk, the market generated a secondary mechanism to pool and manage this uncertainty: health insurance. The standard free market fails here because patients are not rationally shopping for a known commodity with a known value. They are purchasing protection against unpredictable biological and financial ruin. Third-party health insurance introduces a modifier variable that breaks the standard optimization model. At the point of service, patients usually pay a co-insurance rate, an out-of-pocket cost kept artificially low. Because their cost drops, their equilibrium point for consumption slides far to the right. Rational patients will consume medical care far past the point of true economic efficiency because their personal financial exposure is shielded by the insurer. We can verify this theoretical behavior using empirical data from the landmark RAND health insurance experiment. This RAND chart tracks how medical consumption responds to cost, comparing co-insurance rate against total expenditures. For the black dots representing general medical care, utilization drops aggressively as price rises. The white squares for mental health care show the exact same elasticity. The data yields a definitive conclusion. Healthcare is not an inelastic necessity that people consume regardless of cost. It is a service that responds aggressively to price incentives. When an insurance mechanism hides the true marginal cost of care, it guarantees systemic overconsumption. Economic incentives dictate behavior, even in scenarios involving health and disease. Now, there is one final crucial variable that accelerates the spending in this already distorted market: the rapid, continuous influx of advanced medical technology. A treatment like a cardiac stent improves patient outcomes, shifting their marginal benefit curve sharply upward. But acquiring these advanced materials carries a massive baseline cost, causing this system-wide marginal cost to spike. However, if we reintroduce the insurance mechanism to this high-tech scenario, the patient is completely insulated from that true cost. Their perceived cost remains near the floor, sliding their consumption point far to the right, heavily incentivizing utilization. Providers, acting as the patient's trusted agent, are economically incentivized to deploy the newest, most expensive technology available, knowing the insurer is footing the majority of the bill. This creates a compound effect. We have price-incentive patients guided by revenue-optimizing providers. The inevitable result is the hyper-adoption of expensive treatments. The interaction of price-shielded insurance and high-cost innovation creates a self-reinforcing cycle of spending. These rising costs are the logical result of rational actors maximizing benefits when the true price is hidden. When we connect these microeconomic behavioral models back to the macroeconomic reality of the United States, the scale of the spending becomes clear. The figure of 20% of GDP is not an error or an unsolvable mystery. National healthcare spending reflects the aggregate weight of millions of individuals and providers following these specific incentives within a distorted system. Attempting to fix healthcare access or quality while pretending standard economic incentives do not apply to medicine will consistently result in failed policy. Returning to Arrow's framework, we cannot eliminate the biological unpredictability and inherent uncertainty of human illness, but we can redesign the public policies and the insurance structures that manage that uncertainty. The ultimate policy goal is realigning the out-of-pocket marginal costs with the true marginal benefits of care. We have to force the market closer to an accurate equilibrium. True healthcare reform requires us to master the economics of uncertainty, utilizing those incentives to build a system that is both humane and financially sustainable.